All right. So first thing, I'm not allowed to throw anything at me. Everybody deserves a little grace. So, guess what subject was last semester? Transplant. Y'all don't download transplant. If y'all look,
Don't download it?
don't, no. I looked at transplant and I was like, oh dear Jesus. The PowerPoint, yes. It was lacking. A little bit of grace, it was terrible. Y'all don't download it. I might have been drinking heavily when I did it. Energy drink! No! I have completely forgotten. Y'all transfer.
That's so serious.
It was terrible. You guys, it did not have, the information was terrible. I'm like, what was I doing? I taught this entire course by myself. I'm not making excuses, but it was awful. And that is not what I want you guys to see. Now that I've got help, it lets me breathe a little bit. You only have 5 questions off transplant. I am not saying transplant is not important, but that is a very specialized nursing. Y'all will notice that the questions we've given you about cancer are very generalized, more about like precautions. Every nurse needs to be aware of those. For the transplant, you will have a question about neutropenic precautions. I spent a lot of time looking through y'all's book, my book. I didn't find it nowhere. It is on the PowerPoint. You need to look at the PowerPoint. I know y'all know what neutropenic precautions are. Who are those precautions for? The patient. They ain't for you. You ain't worried about eating no fresh flowers? Or not eating.
She might be drinking now.
Y'all see how flustered this has got me that I didn't put out good quality stuff. You are always worried about washing your hands. But you're not worried about, I love fresh flowers. You're not worried about stuff like that until you get to a patient whose white blood cells are non-existent. If you go in there with something like that, you're going to kill the patient. If they were to catch the flu, they're not going to come out of the hospital. So, neutropenic precautions, they're pretty much standard across the board. Don't let 5 billion people come in a hospital room. If you do, you're going to kill the patient. You're going to see a recurring theme here. You have to make them do what to their hands? The patient is in strict isolation. They're not around any of the other patient populations. But I have finished that and it will be downloaded after I leave here. Ain't nobody laughing. Come on. Increased intracranial. Got me under.
Give her a minute.
I try to tell my daughter dad jokes and she's like. Anyway. All right. I love you. You're still laughing. Thanks. We have to do the A and P. What are the layers, the meningeal layers of the brain? What's the first one? Duramatter. Next one. Pia. The pia is what? Adhere to the pretty much brain. No, I'm sorry. Yeah. Dura, arachnoid. Why is that word? It actually looks like what? Spiderweb. Who had like A&P where they did dissection in high school or whatever? Did y'all ever do the brain? How does that dura mater look? It is it is thick and tough, right? It is not what I thought it was when we took that out.
Maybe.
And the human brain is the same way. All of this is important. Why? When we start talking about traumatic brain injuries,
Where
Where the bleeding is.
where the bleed is, that is very important. Now, what is this?
Brain stem.
Brain. What? It is the brain stem. Midbrain, pons, medulla oblongata. What does the brain stem do? What does it respond?
all your survival stuff, breathing.
Your breathing, your heart beating, your blood pressure, everything that's at the very bottom. I don't think sexy time is down there, but everything that's down there, the A, the B, and the C.
Yeah.
We don't get to the S, and not the D. Y'all so nasty. Y'all be cheesy. I saw that TikTok last night. Y'all nasty. Got me in here for a noise complaint, thinking I'm a stripper. So, yes, your respiratory center is here. Your blood pressure control is here. Your heart rate is here. Everything that keeps you alive. Not your higher functioning. It's not there. Your altered level of consciousness is not here. When somebody takes a shotgun and blows their head, the top of their head off, why are they still alive? They hadn't done nothing to this. They'll stay alive until they bleed to death, right? This does not know they're dead. They have an altered level of consciousness. Doesn't matter. All of that, you have to know the anatomy and physiology to understand what is going on with a traumatic brain injury. Oxygen don't go where the blood don't flow. Doesn't matter where there's a periphery. Your brain will not do without two things. What are they? And? Huh?
Blood. Pressure.
Fusion. What was the question?
Your brain will not do without two things. Huh?
Glucose.
Sugar.
We said
Oh,
glucose.
you gotta speak up.
Yeah, I told her all kinds of stuff.
No, I don't count.
You can't say.
We did not.
I'm old. I can't hear.
That's
And she
Yeah, what you say? What did she say?
Get her out.
Enough.
She's gonna fail.
So, we're talking about increase in cranial pressure. So, you have a pressure that's inside your skull, right? You got your brain, you got a pressure in here. Intracranial pressure. What is this? Which is the pressure where? It's in your body. So when you see the doctor's orders, they say maintain a map of 65. What does that actually mean? We talked about in shock. That's what keeps the body perfused. So, this is the pressure that brings blood up to the brain. This is what's trying to get in. This is what's trying to get out. Well, what if this is too high? This ain't gonna get in. What if this is 300 over 460? This ain't gonna get out. What floats around up here? Cerebrospinal fluid, blood. Can cerebral spinal fluid stay trapped?
Yes.
No, it can't. It has to come out. It floats around, right? If you start shoving blood up in there, you're going to get extra blood. There's something we're going to talk about in a minute that's called the Monroe.
Kelly.
Right, you got a certain percentage of everything, right? What happens if you increase a percentage?
Then something gets taken away.
Some got to go. Your roommate gains 500 pounds, you're gonna have to lose some weight. This is not, your brain can't flex. If this goes way up, this is not going to come out. This is going to go up into your skull. Your skull can't flex. It's going to cause what? Damage. Your brain's going to swell, and your perfusion is going to go to kids still shock. Global hypoperfusion. Sure, it's going to start here, right? What happens when it starts pressing on your brainstem? Your respiratory status is going to go down. You're not going to be breathing adequately. Your oxygen level is going to go. What's going to start happening? You're going to switch to anaerobic respirations. What are we going to do? Lactic acidosis. Potassium, you see where we're going? It started up here. It's going to spread. MODS, death. Doesn't matter that it was a traumatic brain injury. It can be a different kind of shock. Maybe it was multi-system trauma, right? You're bleeding out, but you also had a traumatic brain injury. You got insult to injury, no pun intended. 80% brain, 10% CSF. What is cerebrospinal fluid? What does it do?
The brain in it.
It does. Your brain ain't dry. It ain't crispy. Has to stay wet. Blood. What does the blood do? And the CSF?
Brings oxygen.
Does. Takes glucose. Brain needs nutrients. Your skull is a fixed vault. There go to woo-woo at. It won't swell. It's not a balloon. It's not your lungs. It's not your heart. You can get cardiomegaly. You can't get brainomegaly. What's that cartoon? Megabrain? No, it don't work like that. Megamind. Sorry, not Megabrain. Yeah, that don't work. I showed you how much I watched that show. Now, y'all have seen babies that have what? Hydrocephalus. Why does their skull do that? It's not fused, right? They have sutures. It's not fused. Will your brain do that? No. Why does their skull need to do that?
Because their brain
It needs to come through the birth canal, right? If their skull was fused, guess what would not come through your birth canal?
baby.
That baby. It has to flex. It can't be fixed. You don't need to do that right now. You need to do that for me a lot of years ago. It is a fixed vault. If this swells to 99%, something got to go, right? If this goes to 90%, what's going to go? How's it going to go? Through that itty bitty hole.
At the bottom.
What's the name of it?
Something.
Foramen magnum.
Foramen magnum. What is that term called?
Never is.
The patient has started to herniate.
You might agree.
How big is your brain? You guess.
2 times
What's at the base of your brain? So what goes through that little hole first? So what's going to happen first? Everything that happens that is vital to life. Your patient starts having a strange respiratory pattern. Their blood pressure starts widening and their heart rate drops. What is that called? Cushing's triad. Once the onset of Cushing's triad has started, you are way too late. Herniation has begun. Especially if you start seeing what? If you see posturing, herniation is occurring. That is too late.
It's too late if you see cushions.
That is a late sign. This is just my experience. I have never seen a patient where that has started and their posturing come back. And that's transported and that's being in the trauma ICU. I'm not saying it couldn't happen, but I've never seen it happen in 26 years. Now, I've only had probably 30 patients like that, so I mean, I'm not saying I'm in all be all, but I've never seen it happen. Because at that point, something has swollen so much or occupied so much that it's shoving the brain down through there. If this ratio changes, something has to go. Here's the premise to that. Somebody gonna get yeeted. That's the bottom line. Something has to go. Now, how would you treat that by something going? Can you get your DeWalt out, literally, burr a hole, take a window out, every now and then know what happens. You make a hole and what happens? And this is game over. The brain swells out. But that means there was too much going on. But sometimes you take that off and it's just enough. And we'll talk about that at the end about the procedures you can do. But the Monroe-Kelly is a premise for what can we do intervention-wise. This is a 567,000 time I'll say this. You treat the cause. If they've got an epidural hematoma, how could you treat it? Go in and remove the clot, if you can. We're going to talk a perfect world. If the pressure's too much, go in and put a hole, right? If they've got too much CSF, too much fluid. I heard somebody say it. Put in an EVD. What does that look like? There's a picture. There's a little thing. They put a hole. They put it in. So that has two things. Does everybody know what we're talking about? Extraventricular drain. It drains, but it also does what? It monitors that pressure. What's the biggest risk with that?
Brings too much pressure.
You stick in a big probe from the outside in. Huge risk for infection. You have to be real careful with that. I might remember that. So, your central nervous system, its function, the first one is, it's a no-brainer. Oh my God, I didn't even plan that, that's funny. I mean, this is a given. You got to have structural integrity. If your skull looks like Humpty Dumpty, is that structural integrity? No. It's got to have a blood supply. What is this?
Balance.
Our body, everything in us likes to be what?
Balance.
Balanced. If your pH is like this, if I don't have enough oxygen, we're going to go down that road. We're going to start anaerobic. We're going to start lactic acid. Y'all already know how that turns out. You're going to go hyperkalemic. You're going to go down that cascade. You have to have homeostasis. All of these things have to be exactly in order for that to work. Now, what makes up your central nervous system? It's not just your brain, it is your brain and spinal cord. How specialized is this? Beyond. Guys, I'm going to tell you right now, I am not a neuro nurse. Like, I have had to really, like, no, you shouldn't have been in here the first time I did this lecture. I had one of the students that missed work. You might want to read the book. I mean, he didn't say it ugly, but I mean, I stuttered and stammered, I still do. That's not why I'm doing it today. I was upset about that PowerPoint. All this is the Monroe-Kelly. What's going to make it worse? If you have an accumulation of blood, what's that? Hemorrhage. Now, I know that this is not always a traumatic brain injury. That's what we're talking about now. What else is that? Stroke.
Could be stenosis.
Could be stenosis. What else that happens in the brain can cause an increase in pressure that's not trauma?
Sometimes there's
Tumor. There's another word for that until I started giving this, I had never heard of. They call it a space occupying lesion. Why don't you just call it a tumor? Something else.
electrolyte. There's going to be an absorption issue eventually. See what they do.
A problem with absorption of cerebrospinal fluid. They will put in a what? A shunt. And usually that shunt, it comes, the only ones I've seen on the back of the ear, have y'all ever seen one anywhere else? And it comes and it dumps in where? Their stomach, and it's reabsorbed. Somebody said electrolyte imbalance. If a patient is in DKA and you drop that sugar too quick, guess what happens? Cerebral edema. Bad. That's why we have that protocol. You only drop it to a certain degree, then you start an IV fluid with what in it? Dextrose. I have transported 2 patients that one of them when I got there was posturing. It was at a very small hospital. They did not follow that protocol. Their sugar was 70 when I got there. It was awful. I'm not sure that patient made it. One more thing. Somebody might have said it. I heard it. Say it louder. It was over here.
Infection.
Infection. Guys, y'all don't be scared to say. If it's wrong, what? I ain't gonna beat you with a wet squirrel. Dr. Butler said, why a wet squirrel? Why not a dry squirrel? I said, a dry squirrel might bite me. I don't know. Every time y'all walk by Dr. Wilk, I need you to whisper. Anyway, infection. Because you know, an infection causes what? Swelling. What's the bad thing about, what do you say?
I said sepsis, but that's the same.
Well, I can't call. What's the bad thing about infections in the brain? They're hard to treat. Why? A lot of antibiotics don't cross, and it's hard for me to say that, the blood-brain barrier. A lot of them do not. Cerebral edema. So, what are the 3 components? Blood, brain, and CSF. There you go. Now, somebody explain this to me. What's hypercapnia? Too much CO2. What's hypoxia? Too much oxygen. You don't have to explain the pathophysiology of it. What happens when you have too much CO2? What happens to your vasculature? Causes what? Vasodilation. Why do I not want that to happen?
Pressure goes down.
Hypoxia causes vasodilation. I don't want that. I don't want their CO2 too high, and I don't want their oxygen too low. How do we intervene? Put them on the ventilator. You got them little sexy numbers that's out there, right? You have control of that. If they're out of whack, you need to call who? Don't touch that ventilator. They'll cut your fingers off. I might act like I am just to mess with them if I know them. What is the pathophysiology for increase in cranial pressure? A normal ICP is 5 to 15. Guys, I'm not worried about that number. You're not tested. Remember how ARDS, I told you specifically. That's not going to be specifics in this. But just know that above 15 is too high. What causes it? TBI, stroke, tumors, hydrocephalus. What's that mean? Water on the brain. This is the babies. Infections. Why this? What is that? That won't stop. What can increase the pressure in your head? Not to this level. Sneezing. Why? Why? I want everybody, don't poop on yourself, to sit here, look at me. I want everybody to hold their breath and bear down. No, that ain't what I'm talking about.
That's dangerous.
Don't poop on yourself.
That's what I'm saying.
If you're gonna poop on yourself, don't do it. Guess what that does up here? Just a little. If your ICP is 20, can I take a little? Nope. Your patient doesn't need to sneeze, cough, strain. What else? Do I need to lay like this? No. Do I need to lay flat? No.
30 degrees, isn't it?
30 degrees. This is the nursing. You don't have to call the doctor for things. And I know right now you guys are kind of unsure about some things. You don't have to ask anybody. If your patient's head is split wide open and you walk in and they're in reverse Trendelenburg, pick the head of the bed. Let gravity be your... Nobody's going to say anything. Guys, this makes a huge... 30 degrees. Don't. Whoop! That's going to make it worse. Because you don't want to flex their hips up either, because guess what that does? Increases intracranial pressure. Hey, all these things are really important for your test. Neck midline. Don't continuously suction. Guess what that does? No sneezing, no coughing. So if my patient were halfway with it, not on the ventilator, you said no straining, right, Nelson? What medication are they going to get? This is not on the test, but what kind of medication are they going to get? All the time, stool softeners. Now, we don't want it the opposite. We don't want them running everywhere. Do you see how this goes? That's critical thinking. You have to understand they can't strain, no sneezing, no coughing. Those are the meds you might give. If you are, now I'm not saying if they're on the ventilator, you're never going to suction them. They're not going to be on continuous. They're going to be on what? Intermittent. You control it, not that wall. And don't be letting nobody go in there and mess with your suction. That's up to you. Neck needs to be midline. Now, if it was a diving accident and I'm worried about that, they're going to have on a what? You need to check it's not too tight. Nothing needs to increase that pressure. How might these patients look? Is an altered level of consciousness unconscious? Guys, there's a range. It can be anxious. It can be irritated. It can be combative. It can be one end of the spectrum to the other. It can be A&O times 2. It can be A&O times 1. It can be a little bit confused. It can be a bad headache. It can be sleepy. What is a flat affect? Oh, look, I cut my arm off. Look at there. I love you. A lot. You learned that in psych. What flavor of nausea and vomiting? Yes, and it is vomiting with no nausea. There's no warning. You finna get thrown up on. And this looks like, not the new one, but the old Exorcist. You're sitting there and all of a sudden you just got puked all over. There is no warning. There is just vomit everywhere. Because usually when you're sick, you get that, your mouth's watering, you know you're fixing to throw up. You might get a little bit of, no, there is no warning. And it is like across the room. These are the early symptoms. The worse the injury, the quicker you what? Progress from point A to point B. If it's an awful injury, you might skip point A. Cushing's triad, what is it?
Low heart rate,
Breathing.
low oxygen
Systolic.
breathing, and wide.
Now, it is a high systolic, but you said it's a widening pulse pressure. What does that mean to you?
It means that the difference in the systolic and diastolic is getting bigger.
Right. So if I start out at 110 over 80, what's the next one going to be? 160 over 80.
Yeah.
Then what?
Get bigger.
200 over 80. Then what? 300 over 80. Does that fit the picture of shock? It doesn't. And the heart rate's 40. Now that kind of sounds like what? It kind of sounds like spinal shock or neurogenic shock, but what was the blood pressure?
Oh.
It was in the toilet, right? That's not neurogenic shock. This is Cushing's triad, not Cushing's syndrome, because that was what? That was endocrine. Don't get it confused. This is, I told you, NCLEX loves crap like this. Cushing's triad. Beck's triad, which was cardiac tamponade. Cushing's triad, a widening pulse pressure, elevated systolic, bradycardia, dropping respirations, or an irregular respiratory pattern. I'll tell you right now, it's dropping respirations for me. Pupils will be what?
Fixed, dilated, different.
They said that at first it'll be ipsilateral. What does that mean? One side is fixed and dilated and the other is not. That's how it'll start. You might miss that, and then it's going to be what? Both sides. Then what? Posturing. Then what? Flaccid. What are the posturing?
Decorticate.
Decorticate is towards your spinal cord. Your arms come up, curl up like this, and your feet go out, right? Your arms are towards the cord, spinal cord. What is decerebrate?
Away.
They're out like this, your feet still do that, which is, this is kind of a messed up thing to say. Which one's better?
Decorticate.
No, decorticate.
Decorticate.
I never knew this until about 6 years into my paramedic degree career. Can you go back and forth?
Yes.
You can. And I was like, oh my God. Oh my God. I was like, that's the coolest thing ever. I'm supposed to be doing something. Because the lady was like this, and then she went like this, and then she went like this, and then she just went like that. I never knew that you could go back and forth, but you can. Was she low sick? Yes, she was fisting to go see Jesus, and she did. Like we got to her, she was an hour out, and had got run over by a tractor. Yeah, she did. She was bad. But guys, once you get here, it's such a late sign that Jesus is waiting. That projectile vomiting means that pressure has gotten really high. And things are progressing in a direction we do not want them to. That's just a chart to show that again. What is this?
Oh, the brain.
There's 4 or 5 different types of herniation. Guys, I'm not trying to get y'all to memorize what this is. I'm just trying to show you what it looks like. This is a normal cerebellum, brainstem. Look, that's the same brain. There's your cerebellum, and that's your brainstem. There's something else strange about that CT. What is it?
Ventricles are closing up too.
They are.
You
And
see
what else?
the grooves are like spaced out more in the brain.
Actually, it's flat and it's fuzzy. You know what that means? Huh?
Edema?
It has swollen so much. The grooves, and I cannot say that S word. Somebody. Sulci. Yes, they're smoothing out. I don't know how you. It's the little squiggly sulci. Y'all know what I'm talking about? It's not grooves and lands. That's a bullet. Your brain has the little wrinkly things and the grooves, and I cannot pronounce that S word to save my life. It's not shit. It's the other S word. Yeah.
Septum, right?
SU.
No, that's what.
Sulcus.
Sulcus, thank you. The sulci, yes. The brain has so much edema, all your little squiggly lines has turned into a solid surface. Yeah, it's game over. But you are right, Patrick. You see that the ventricles are starting to close. And if we didn't have the sideways, if you were looking down, you might see that it has what? Shifted to one line. Y'all, if y'all are in the CT control room, you might hear them say, hey, they have a midline shift one way or another. So much swelling or so much blood, they're pushing it one way or another. Like you see here, that space is basically gone. This patient has probably started posturing. And it will continue to shove until what? The patient goes into cardiac arrest. What medication do you think we would start giving immediately? Just guess.
3%?
Maybe mannitol, but usually what? 3% immediately. Why? This is a Hail Mary,
Yeah.
but it has hellacious diuretic effects. Guys, this is it. Cooling ain't gonna do nothing. All I can try is to pull the fluid out and hope that this might go up enough to stop that. Maybe we can get him to surgery. if we are running down the hall to put that burn hole or to do that craniectomy, and I have them on an ambu bag, I'm asking y'all to think, what might I do? Huh? It causes vasodilation and can decrease their pressure.
So start breathing through.
Like, not like a,
What'd you say hypercarbia does? So, if vasodilation increases the pressure,
oh, would you like give them more oxygen to clamp down?
if hypercarbia causes vasodilation, if too much CO2, what if I blow off all the CO2 by
It is.
hyperventilating?
Did I say right?
Huh?
Would it be a
No,
light?
it's a, you just have a medium.
There you go. I am running down the hall to go to the OR. How can I blow off their CO2? By increasing
Yeah, they're-
the amount that, you don't do this, but just for a second.
Once every 5 seconds.
So hypercarbia means too much CO2. They're not breathing very much, right? Vasodilation. If I can hyperventilate them, I blow off all, guys, I'm just trying to get you to think. If I can blow off all that CO2 and cause vasoconstriction, maybe, till we get to the OR and can get that window and let the pressure off, maybe it'll help a little bit. God, we ain't got nothing else. They're herniating. 3% saline, hyperventilate, and pray. And run real fast. Right? Treat the cause. How are we going to assess these patients? What's the first thing you're going to do when you walk in the room? This is every time. Hey, how you doing? What's your name? Who is this sitting next to you? And if they say, this is John Deere, and the person's like, then what are you going to start doing? What's your name? What's your date of birth? And then the person's like, okay. Who's the? Guys, this is a geriatric patient. What's your name? What's your birthday? Who's the president? What color is it? What's the sky? Don't rapid fire. They're going to get confused. And you're like, oh man, they got the worst altered level. No, they don't. One, they couldn't hear you because we old and we hard of hearing. Hit her. Guys, they get confused and they shut down and they're not going to answer you. I don't know what day it is on my best day. So, if you're asking them these questions and they seem kind of confused, ask them something they should know. If you've asked him, who is this sexy gentleman sitting next to you? And they get all flustered and they say, it's my husband. And then he's like, yeah. Or ask him, one, are you colorblind? No. What color is that? Ask them something they should know. And then kind of progress to a little bit harder question. Do you know where you are? I'm at the White House. Well, maybe not. Sometimes you have to kind of get creative with people. What's another population? You might have to ask different questions. Children. Changes in level of consciousness are always not like you walk in and they're passed out. You might walk in and they're like, can you tell me what your name is, Shayla? Now, when I came in, I wasn't doing that. I'm just anxious. Is that a change in look? Yes. I just don't feel like something's right. Now, if you come in and I'm like, Shayla, huh? What? Can you tell me what your name is? checks. What else is involved in that?
Pupils.
Don't go in there and the lights is like this and I'm standing under it and I've been looking at it for 30 minutes and check my pupils. Oh my God, they're fixed and dilated or they're so constricted. You've been taking drugs. No, I've been staring up at the light. Everybody's heard about when somebody comes in with a stroke, what kind of exam do we do, right?
Yeah.
There's part of this that I'm gonna do when they haven't had a stroke. What is it?
The,
I wanna know their what?
for the string.
I might do the arm drip. That's important with this. How do I do it? I'm gonna ask her, and so if she's just like, I'm gonna say, what, you squeeze down like, "Argh!" And then I'm like, "Ugh." So, but if she's like, then don't say anything, because you don't wanna upset them, but if there's a marked difference, then what am I gonna do to their feet? I need you to pull up against my hands. All right, I want you to step down. Don't squish my fingers like you pushing on the gas. I need to know if there's a difference. I need to check their pupils. If you walk in and they're posturing, that's not good. Can a seizure increase intracranial pressure? For more ways than one. Can a fever? How? So, if I hit you in the head with a baseball bat, your brain swells, right? That's the primary insult. Then your respiratory rate drops. Then your oxygen level drops. What is that? The what injury? The secondary injury, right? If I have a fever, what happens to your metabolism? Goes up. Oxygen demand goes up. If I was hypoxic to start off with, do I want my metabolism to go up? I do not. A seizure is an electrical storm in my brain. What does it do to my metabolism? I do not want them seizing. What medicine will they give them? Either Keppra or a lot of times phenobarbital. They will put them into an induced coma. Give them Tylenol prophylactic. Guys, I have never given it this way. How can you give Tylenol? Oral, suppository, and IV. I think it's very expensive. I have never given it IV. Has anybody ever seen it given?
Yeah, 1,000 milligrams.
Is it red?
No.
Like I said, I've never given it. I think it is pretty expensive. Where did you see it given? Okay.
We do it all the time.
Really?
I think I've been given it before. It was a Bach.
Did y'all give that same dose? 1,000 milligrams? Did you? I feel like I'm missing it. I don't want them to seize. I don't want them to have a fever. I don't want anything that's going to raise their metabolism, that's going to raise their oxygen demand, that's going to cause hypoxia, right? That's going to make that secondary insult worse. What if they have an infection? It's going to make them have a fever. It's going to make them have inflammatory response. It's going to send up their metabolism. I need to treat the infection too. Now, is that their traumatic brain injury? Nope. Let's say they have an open skull fracture that they had doing motocross out in the field, and they fell in the pile of cow manure. And now they have a hellacious infection. Their metabolism is going to go up because they now have sepsis. Does that have anything to do with this traumatic brain injury? Not really. They now have sepsis and a traumatic brain injury. Don't let that metabolism go up. What else might they put on them? A cooling blanket. Now, when you get cold, you shiver. What kind of med are they going to give them? What kind of medication will stop muscle action?
Oh.
Huh? Presidex, or it paralyzes
Oh, like.
a paralytic. If you shiver, why do we shiver? To create heat, which increases your metabolism. You're shooting yourself in the foot. You will see them put the cooling blanket on, which is pretty cool. You will see them give them a paralytic. You can't let them shiver.
So like rock,
Huh?
like rock through it.
This is the only time I've seen, and like I said, guys, y'all have to understand, I worked at Vandy 10 years ago. And y'all might do this all the time. This is the only time I've seen them give Nimbex, Sister Curium. Y'all ever? It's a paralytic because it's not processed in the kidneys. How well you think that kidneys is working? Not at all. It's processed in the plasma. They didn't shiver, but I had to call the pharmacy. I had never given it, and I'm like, how do I give it? What's the rate? Is there anything I need to know? And you know, they love talking about stuff, so I won't call for 30 minutes. I'm like, I gotta go. I think the patient's crumbling. I need to look for what? How do I figure out if it's? It usually comes out ears and the nose, and there is this. I didn't put any other kind of skull fracture, but a basal skull fracture on because that's very important. We need to look at their pupil. Pupils are equal, round, to light and combination. What does this mean?
That they shrink when you shine the light in it.
Right.
Like if one does now.
What?
Accommodation.
What did you say, Alex?
Or one people does, the other does.
Right. What is the first intervention? This is important. What's the first thing you can do? I ain't got to ask God or nobody. Elevate the head of the bed. Top 3 priorities with this patient. Assessment, that don't count. I need to do everything I can to do what? Bring that pressure. Guys, do the simple things first. Elevate the head of the bed. Do the simple things first. Now, what if it's a diving accident? I also need to keep one in mind. C-spine. Don't just go in there snatching their neck around and their C-spine hasn't been cleared. And don't think it don't happen, right? You have to be aware of all of it, the big picture. They might have a traumatic brain injury and a spinal cord injury. Why this? If they've had a brain injury, they might have what?
Seizure.
And they're not a seizure patient. And if they have a seizure, it's going to do what? Increase their intracranial pressure. You might have a whole hellacious situation you didn't start out with. You got to keep their temper. Might you be doing these things prophylactically? You might give them Keppra and they're not a seizure patient. Well, they ain't started seizure yet. Nope, don't want them to either. Well, they ain't got no fever. Nope, don't want them to either. What am I going to monitor? Labs, yes. What labs? White blood cell count. I don't even want to see it creeping up. Because not only it be a systemic, it might be where? In their brain. Do we need surgical intervention? Do I need a drain, craniotomy, or decompressive craniotomy? Y'all, we were in the ER at Vandy. I swear, I don't want to say this doctor just got this from maintenance. I don't know. How can you walk out of the room, walk down the hall, and come back with a drill? it wasn't from the stair, like it didn't have, do you see what I'm telling you? It didn't have the little paper stuff, it didn't come in a tray, and all of a sudden you got the drill. I'm like, you went down to maintenance and got that, and poured betadine on it, and you're like, zit! I mean, the patient lived, I was like, okay, you're gonna get the Black & Decker from, you want to, can I borrow this for a second? Anyway, what kind of diagnostic, what do you think the first one is? We're gonna do a CAT scan. It's probably not even gonna be, it's not even gonna have dye. This is not an emergent diagnostic. This is gonna be what? 3 days later. What labs? White blood cell count, CBC, CMP. I wanna know their electrolytes because they can't get out of whack either. What is that? Y'all know? It's a CTA. Somebody guess. It is a CAT scan.
Is it with contrast?
Huh?
With contrast?
It's an angiogram. It looks specifically at what? Y'all don't have to write that
The
down.
vessel.
It does. It looks at the vasculature specifically. It can see what? Very small tears. Now, there is a diagnostic they can do that we have to be very, very, very careful with. What is it?
Oh, spinal tap?
Why would I have to be real careful with that spinal tap?
Because your CSF's already out of whack.
Pressure's high.
Paralyzed.
So if your pressure's high,
It was
what else can run up your metabolism and oxygen demand? Anxiety and pain. Has anybody, I have never had one. Has anybody ever had one? Did it hurt? Guys, look, I'm clenching already. I can't even imagine somebody coming at me with an 18 gauge needle that's this long and gonna, hey, can you bend over this table real quick and not move because you might be paralyzed and I'm gonna stick this great big needle in your back. Okay? Yeah. And it might make you bear down. Right? All the things I don't want to do right now. So it's kind of a walk in the fire. I might want to know if you have an infection though, right? And is there any other way to know specifically that you have meningitis besides that? Is that going to be your first go-to? It is not. If I think you have a traumatic brain injury, I'm not going to do that LP first. I'm going to rule out some other things. Then I might do that. Now, if you have an infection and I put that LP needle in and I'm getting flow out, what is that going to look like? It's going to be icky. It might have pus in it. It's not going to, what does CSF look like?
clear.
It's clear. It might be a little bit of a tint to it, but it does not. Have y'all ever seen that?
Yeah.
It looks terrible. Like it is either cloudy or I swear it looked like it was just straight pus dripping out of there. It was nasty. It might have other, and usually it is just white blood cell, and so they'll take I don't know why it's 4 tubes. It's always 4 tubes. They'll take 4 tubes and they'll send it down to the lab and they test it for all the things. But they do that very carefully because we don't want to increase the ICP if we are suspecting that it's already high. We already talked about the meds. We don't give mannitol as much, but some places don't have 3% saline. I don't want you anxious, right? What kind of meds do we give for anxiety in our world now? Benzos, what are they? Give me the other names. Lorazepam, which is what? Ativan? What's the name? She said Valium. We already said lorazepam. There's only 2 more.
Xanax.
Who said it? Say it louder. You're right. Diazepam. There's 1 more.
Oh, liver.
We give this one a lot more.
Hold on.
Starts with a V, the trade name. Versed, what's the other name? Starts with an M. And ends with a Pam. Or ends with a
Oh,
lamb. Bedazzle. Guys, y'all have to know the generic names. They are not testing you on the NCLEX with trade names. Midazolam, lorazepam, and what? Diazepam. Those are our anxiolytics. What is anxiolytic? It is the drug class.
So those are given as sedatives.
In little doses, they're given as anxiety drugs. Now, as sedatives, larger doses, why would I give a bigger dose if I'm going to do what to the patient?
Something that would cause that.
Well, I'm probably going to intubate the patient. Sedatives, narcotics, paralytics. Because I don't want you to know I have paralyzed you and you can't breathe and you're conscious, right? That's torture. Not that that ever happens, right? Right?
What?
I said, I wouldn't want to give you a paralytic and you be conscious and know you're dying. That never happens, right?
I'm sure some hospital provider does.
Why don't y'all stand up for a second? I want to figure out where we're gonna.